section in the area of major anatomic structures. You start with dissection here by gentle grasp of the tissue. It is the level of peritoneum that we call the peritoneal envelope that covers the cystic duct and artery. To use the electrocautery, you pull up a bite of tissue and use electricity cautery to break through the peritoneal layer. Yeah, okay? And then you can do a blunt stripping and spreading the tissue to expose the anatomic structures. In real life, in a patient, the peritoneal envelope is pretty short in this aspect. So to develop the pedicle of a gallbladder, you need to take down this part of peritoneal envelope and release this tissue so that the cystic duct and the artery get very mobile, and then you get a much better exposure of a triangle of Callot. The critical view of safety is mainly exposing here the base plate of a gallbladder and see that 1/4 of a gallbladder is released from a base plate from the liver bed, what we call. Yeah? To access this area easily, this mobilization of this area facilitates movements, the so-called sail movement with the gallbladder, so that you expose it once from posteriorly, then you can go a bit here and here, so that you expose nicely this part of base plate that you see there is gray, which is the gallbladder bed. So use of cautery in the area of the structures of the triangle of Callot and area close to common bile duct and hepatic duct should be very restricted, because there's always danger of a thermal damage by the use of heat, by use of cautery. So as less as possible, because stripping with fatty tissue will not cause a major bleeding, some little oozing. There are no vessels in this area that could bleed, of course, a major problem. So again, now you detach the tissue around the cystic artery here, and you see nicely there the base plate of the gallbladder, here the area of the cystic duct, and you see that it is pretty clear that this structure is looking like a funnel. It is broad at the top towards the gallbladder and gets narrower down. So it's certainly a cystic duct. Yeah? The other structure that shows there is here, is the cystic artery, and it obviously goes into the gallbladder, not into liver, so it is not the right hepatic artery. Yeah? Now, the next step will be to develop these two structures so that you can place safely a number of clips. The length of the structures you can easily recognize, because you know that the length of a metal part of the instruments is about 2 centimeters. So it means that you have a length of a cystic duct in view and the length of an artery in view of about 2 centimeters, that means that it will allow you to put enough clips. So don't go there because it's dangerous. Here is hepatic duct. You have to avoid it. Still, you need to remove a bit of this tissue because the clip will not work well if there is too much tissue inside of the clip. So still we need to do a bit of dissection. Here. And still a bit of peeling off the tissues. And blunt dissection, opening the dissector. Here, step by step, and see very clearly that now the critical view of safety starts to develop. Here, nice base plate, 1/4 of the gallbladder is mobilized. There is enough space at the cystic artery to maybe we should detach still this string, yeah? Okay. Okay. So now I would ask the trainee if he is happy with the length of the structures and if the view of the critical view of safety is according. So what you think about your dissection? Yeah, that's a good idea still to improve it there. Yeah. So we now accomplished actually the component task is the dissection of the structures of the pedicle, the cystic duct and artery, and creating the so-called critical view of safety. It means only 2 structures go into the gallbladder, that is cystic duct and cystic artery. Yeah? So this component task is now okay, you're happy, I'm happy, and you avoided getting into the dangerous area, because this dangerous area is here, that is hilum, where the hepatic duct, common bile duct, and the portal vein, and the arteries are there, right, left, and hepatic artery, where you should not be because you can damage the structures. Okay, so now we go into the second component task of the procedure, is taking care of the structures by or putting clips, or if you are very good in tying knots, but you can ligate these structures with piece of suture. So we have here no possibility to ligate, so we choose a clipping device. Yeah? That's another instrument that OR nurse had already prepared and is on the table. So that is the multi-fire clipping device, and then is taken care of the artery, the dip. Yep. Super. And again, what is very important, that there is some distance between the 2 clips, because if the clips are too close by each other, then they can pull the tissue out from the first clip, and it will be insufficient. So you see a very nice distance between the clips, and particularly between the 2 central clips and the clip that is more on the gallbladder side, because here you can leave a big cuff of tissue that will avoid that the tissue slips out of the clip. So technically, clipping of the artery is actually almost perfect. And you see that now he's placing the clip centrally on the cystic duct. Nice view of a tip of the device so that you can see that there is no other tissue negotiated by the clipping device. And again, most important are the two central clips, and less important is the one on the side of the gallbladder, because this tissue will be anyway removed. So, okay? Good. So, the second task of this procedure, placing the clips, is done. So we had the dissection, placing the clips. Now, what we need is to find out if there is a nice scissors to cut the structure and to transect the cystic duct and the artery. And now there will be another question, is what should be done first and what should be done second. If it's easy, it will be better to release the artery, because you can very easily tear out the artery from the main right hepatic artery by pulling on it when you already transected the cystic duct. But sometimes it is difficult to see or difficult to access, so you can change the sequence. But again, preferably taking first the artery down. Okay? And again, taking care that there is enough tissue cuff on the top of the central clips to avoid that the top clip easily will slip off. Okay, so now we have a second part of the procedure that was that was taking down the artery and the cystic. And what follows is now mobilization of the cystic, of the gallbladder by means of either hook or the spatula. My preference is for spatula because it can be used as a blunt instrument and also as electric knife, and also as something to control the small bleedings from a gallbladder bed, because you can use the surface coagulation with this instrument. If you use hook, it has a small surface and it tends more to cut in the tissue. So again, the choice would be to use the spatula, and spatula can be also used for blunt pushing off, and sometimes it's easy to push off the gallbladder from the gallbladder bed if it is not fibrotic or inflamed. Okay? So we have now the fourth component task is removing mobilizing the gallbladder of the gallbladder bed. If you use this systematic for whatever procedure in your profession, then you can again find this kind of elements, this kind of steps in any procedure. The next step in procedure will be removal of immobilized tissue. In this simulation program, it goes automatically, so it's not much fun. Other way, you need to pull this gallbladder through one of the incisions, preferably in some kind of plastic bag or handshoe element also, to avoid that there is spillage of maybe contaminated bile into the wound of the patient. But it goes here automatically, so you'll see that the retrieval bag shows up and the gallbladder is gone. So we had another task then accomplished. Yeah? Now, what you need to do is to check if there is no bleeding or no other problems. There's pollution, you see retrieval bag, things are put in and removed. Yeah? When you check the operation area and see that there is nothing going on, everything's clean. If there was some pollution, you can wash it out, the debris, and remove it. Sometimes you need to put a drain, sometimes not. And the very last component task is to check on the insertion places of the trachas, because there could be a bleeding out from the wounds that were perforating the abdominal wall. So we are down to, I think, 7 component tasks of the procedure. Yeah? Okay. Now, you know exactly how I like it to see that the end product looks like. No dissection further on, only dissect it as much as you need it. Avoid getting too centrally close to the common bile duct. The machine will show you that the dissection was not 100%. Because if you would go for 100% dissection, you could cause ridiculous.
You come. Sir, he is a novice. You are exposed to the mentor. But sir gave instructions almost, even if I am doing the surgery, my ear is to him. But he is telling, let us see. Let us see. Sir, he is almost from another medical college, from Katuri Medical College. You are doing lab only. He is doing, but he is not well versed with the mentor. So let us see how he will do this task.
Okay, now you're the instructor. So see, that's the difference. That is an issue that we mentioned that is important. That you guide the trainee through the procedure before he just starts to do it to get the numbers out of the machine. He has to do it so as you, as a trainer, as the surgeon or specialist, gynecologist in case of hysterectomy or whatever, you want that it is done this way. And you indicate the regions of danger and you help in choice of correct instrument. Other way, people come, take something and are messing around, and then they come to you and you say, where you learned this? From a machine. No. Yes, to use what you use the way you want him to use it. And the operation and the end of any procedure, whatever procedure you let the trainee, should be as you like that it looks like, the image. Yeah? Okay?
Yes, correct. Yes, yes. Okay. Change the center and click now. Stuck clicks. Now next. This side. That is go to the dissect. Go to the dissect. Don't click completely. Just now you see, then tuck. Correct. So there are two instruments. Two instruments. Right. This is suction irrigation mechanism. You see, just don't click completely. Just now hold the hammer. That much food is not required. Slow. This one should not open. Very small open. Yes. Just no. Just into this artery and down. Just small. Just hold a little bit. I ask her. Very small open. Yes. Small opening and so. Small opening. Some posterior and anterior like that. Change the direction of the right wrist. Temperature of the right hand. Right hand. Temperature of the right hand.
Students could another
Yes. Go. Change the direction of the right hand. Yes. Just try to hold in the teeth, not to hold into the body of. Change the direction. Yes. So that you can see the palm. Correct. Even if it is a laparoscopy in the mental, still we should think, yes, we are on the patient. We should not think, yeah, nothing will happen, we will go on doing the procedure. It's not going up. Yeah. Cool. Just we have to see all the. Again, yes, nice. Slowly, slowly, we are coming to the. Yes, we are seeing this side coming. This much pull to the one, but left hand should yes. Just this one should be. You are holding na. You are holding na. You are pushing out. Just this one. So go like this. You see now, like a pivot movement. It should, like arc movement will go. That's small movements. Here are the artery and the liver tissue. Same thing we are doing in the operation theatre. Very gentle. Don't open completely the mouth. Still. In the posterior, you can see some of the fringes in between the top and the toes. In between the top and the toes, some of the fringes are
Very good. What is the task? Next, what is the task?
Then we already discussed this with them, so we will now put the video of the suturing and give them forms. So, but I will talk first of our assessment protocols. when it is done, we will give a short talk about the assessment protocols, and then let them assess the suture, and then the day will be done. Because it's now 3 already, and at 4 we end. I know we suggested that 4 should be.
Yesterday, on the PT were doing this. After that, I had a doubt. I told him go to the ophthalmologist. So, actually, he had a problem. Because what happened? He is going, and there, exactly, he is seeing that, and he is crossing that limit. And after that, he told, these are my eyes. Because he is going, but he is crossing that target point.
రాలేదు. లేకపోతే ఎలా మీరు చేస్తున్నారు కదా 2 రోజుల్లో పెట్టుకోండి, ఓపెన్ చేసి చేస్తున్నాను. ఫస్ట్ నేను ఇన్స్ట్రక్టివ్ వేసి కనీసం ఆయన యూరిటర్ మొబిలైజ్ చేసి అక్కడ స్టోర్ చేశాక నేను 1 లీటర్ ఫస్ట్ ఇప్పుడు మాకు 1 లీటర్ ఫస్ట్ సిమ్టమ్స్ వాష్ ఇస్తారు. అదే కిడ్నీ అంత ప్రాక్సిమల్ ట్యూబ్లో పెల్విస్ వరకు తీసుకెళ్ళి అంటే ఇంకేమైనా ఉన్నాయా స్టోన్స్ అని చెక్ చేయడానికి చేస్తారు. అది పెట్టాను కిడ్నీ ట్రీలోకి పెట్టాడు. అది వస్తుంది యూరిన్ ట్రీ కవర్ అంటే పీసీఎస్ వరకు క్లియర్ పెట్టాడు. జస్ట్ హైడ్రోజన్ ఇంకేం ప్రతిసారి పంపిస్తున్నాను. ఎందుకు సిఎన్ఎస్లో ఒకటి ఉందంటే మీకు అవన్నీ అసలు స్కిన్నే లేదు. అప్పుడు కూడా అప్పుడు అవసరం ఏంటంటే టీచింగ్ అప్పుడు చూసేది ఒకసారి ఇంట్లో మైనస్ వాళ్ళకి ఏంటి డిఫరెన్స్ ఏంటి మనం చేసిన వాళ్ళు
అది
So can we switch to the projection?
మనం ఎవరైనా తెలియదు.
Where's our program? We are offers our films, but our presentation is. Oh yeah, it's done. It's just your training, but our yeah, this one training. So. Yeah. So now we had we have spoken about a lot of things as instruction, a way of demonstrating, and now we come to the essential point of measuring the result of the training and looking how we can assess the outcomes of the performance and what are the tools and ways of assessing it. Because if you don't measure, you don't know what you get. Whatever shopping you do, you want to know what you're paying for, so you need to know the weight and the size and the form of a product. So measuring is knowing if all this effort put into the training was worth doing it. So there are different methods, manners of measuring it. The machines, the VR simulators, the simulators, the augmented reality simulators, they have a capacity of measuring certain parameters, but usually we have a problem that they really measure what we see. We don't measure the image. We measure the trajectories, the velocity, the ergonomy of movements, the time. But these are the parameters that have a strong relation to the product, but they are not really the photographic outcome of the operation, what the surgeon of a procedure, what the surgeon sees at the end of the procedure. So it's objective, it is very supportive, but for certain applications or for certain elements can be misleading. So we are still working a lot with more subjective tools that are based on observation by the expert, by the mentor. And of course, all these tools are entitled as being objective, most of them, but they are very dependent on the observer, on the way how it is observed, and also on the experience of the observer in use of certain forms. Because if you are not used to a certain protocol, then you may have problems with the assessment as such. And these rating skills are different. Some of them are procedure specific, some are very generic, particularly for basic skills, and some are combination of both. They are applicable certainly to the skills lab setting, and certainly also for the basic skills. They are applicable for the settings in the workplace, whatever the workplace is, if they are, of course, accordingly structured. They are certainly also very useful for the simple administrative purposes, because these forms can be placed or computerized or placed as a paper in the portfolio of the trainee. We work nowadays for training of medical specialists with the portfolios, where all these assessment protocols are collected, and each year the trainee has to submit a number of such assessment protocols that are put into his portfolio, and at the end of the training period they have to be discussed with the committee, a training educational committee. So one of the very classic is global rating scale, not used in our experience. All of these protocols, before they are really valid, should be validated, I mean tested by a respective group of trainees and by number of procedures, and done, of course, by different assessors, so that you can test if they are working correctly or they are not working correctly. Yeah? Okay? Rating skills for generic skills is pretty well known because it is used for the American program of basic skills for fundamental laparoscopic skills. So in several countries, and certainly in the United States, it is pretty standard used protocol. Goals, a similar concept, but less applied, developed and validated for 2 procedures only. Work actually a bit better than standard checklist systems, but still not very broadly applied. If you look at observational clinical human reliability analysis, it is very good protocol for observing and assessing processes that are very extensive and prone for serious adverse events. Comes from industries, is very time consuming because if you apply it in a clinical setting, it necessitates almost looking at the registrations, video registrations, almost frame by frame. So if you have a laboratory process that has to be done very meticulously, it could be applied. But this is a very, very tough work, and it is not for daily life to assess the trainee in a clinical training. The protocol as a global assessment gastrointestinal endoscopic skills is pretty well accepted in Europe and used for other procedures, for surgical procedures. OSADS is almost a classic internationally used protocol that allows to assess any procedure. It's not procedure specific, any surgical procedure or other procedure, any kind of surgery that really allows to assess also the aspect of set. It means that all the elements of the procedures, not only procedure specific, but as positioning the patient, knowledge of instrument, handling of instruments, and also the knowledge of the procedures can be assessed. That is a tool that is used in the training program of surgeons in Netherlands as obligatory. You need to have unless 10 to 20 within each year of your training from different procedures in your portfolio before you can sign off the year. It is pretty easy to handle. Global assessment scale, we use it within the it's procedure related. So for each procedure you need another gas form. It is validated. It exists for many different procedures, mainly surgical. It can be developed, of course, when it will need to be validated for the gynecology or other procedures that you are assessing. So this is also something for assessment in the clinical setting at the workplace. Yeah? Okay? Very simple, so it does not consume so much time. It's pretty well accepted by the mentors because there is only a very simple question for each item and it does not take much time, and then you can collect a number of points, and if you achieve a certain number of points that is set up for a certain procedure, then you can sign off the procedure. Okay? Another tool that we may use today by assessing the suturing is the CAT forms. It is again very specific, for procedure specific, developed for surgery, but it can be used, for example, for suturing. It is mainly to assess the video recordings of the procedures. It's why it comes from a program in UK that was a laparoscopic colorectal surgery program, where it was developed for colectomy and assessing of videos. And it really shows the differences in competence in performing. Available for other procedure and specifically for not trying as well, and validated for it. So it's a bit more complex. We modified it so it shows, for example, for cholecystectomy what is good and what is wrong, to make it a bit easier for also self-assessment. As I mentioned already, self-assessment in surgical skills area is very important, because we notice that self-assessment is reliable. The self-assessment provides also a good information about other inanitive traits of individual trainee, because we can see if people are over-assessing, under-assessing them, so certain characterological aspects of the trainee can be also identified, not only the purely technical aspects. So, self-assessment, of course, has also a lot to do with the what we mentioned, reflective way of training, because if someone is trained already in the way of reflecting on his performance, he can handle this very well. There is something that is also pretty important if you train in the setup of a skills lab, a group of trainees. Then if you use self-assessment, you reduce the number of mentors that have to observe the trainees. So it has a practical, economic aspect that you may have in a group of 12 trainees. In place of 3 or 4 mentors, you can have 2, and then they can cover easily the assessment process at the boxes and at the simulators, observing at the same time more than one person of one group. So that is the strength also of self-assessment. As I mentioned already, surgical professions are usually triggered to self-assess themselves, because you cannot hide your complication, they will show anyway. So it's why it works, and Sandeep has done pretty good research showing that it really works, and there is a positive correlation significant correlation between the expert assessment and self-assessment, but supports this component. Then it's also confirmed by some other publications. So what we'll do in coming half an hour, we'll give you an opportunity to use the cat's own suturing. We'll show once more the video, how it is done, actually very good. We distribute first the forms, so please look at these forms. What are the questions that they are posed there? And then I'll show you 2 short video clips of someone who performs. You'll find out how he performs, and the other how he performs, and you can then judge. But if you can assess the performance correctly by using this kind of protocol. Yeah? Okay? Can we distribute the forms? And I'll start. Oh, I cannot find this vignette to get out of it. Usually it shows somewhere here, but it does not show. Oh, yeah, okay. Then we go close this. Yeah. We need to get out of this problem and go to the demonstration video. To the video that was suturing. The normal, yeah. So that we see once more normal. So this is the how it should be done. And if you look at the forms, then you'll see that it is important to look very critically on how the people handle the needle, if there are needle drops, if there are errors if the both hands are used, so if the process is bimanual. So this is just, let us say, optimal way of tying a knot. And if you look at all these questions in a questionnaire, that it would be scoring perfectly, this one. After you memorize a bit how it looks in an optimal setting, then I'll activate one that is done by someone in training, and then you should notice the differences and then score it accordingly. To avoid using many forms, use, for example, a cross for the first and some other symbol for the second, so that you can see the differences also in performance. And then you can tell what you think that was the best. Samir, could you score one of these videos? Again, now how I get here out.
So we have to score them. Number of errors.
This is normal. It's hearing. Video na. Play అవ్వట్లేదా?
Okay, that is the first video that you have to assess and look how he is performing. I think it takes few minutes. So. There is evidently a little bit difference with the other one. Yeah. It means that you lose a lot of suture.
Yes, sir.
At the end of the go, you have effective part of the suture is wasted by too long tail, and the tail comes always in and out. I'll tell you, that is someone that pretended to be a colorectal surgeon doing advanced procedures, in doing bariatric surgery in Saudi. So I don't think I would like to undergo bariatric surgery by him. He did not reflect on what he was taught because the suture is hanging down. And when it is hanging down, you can merely make a hinge. See, struggling and in place of stopping and reflecting on what's the problem and supinating his left wrist, he would immediately be able to do the hinge. And the left hand is dead. He's paralyzed on his left hand. It does not move at all.
Everybody has to face this situation.
And the knot is also not approximating the tissue. But for the ladies, it's important to know that it was a guy, so he was very self-confident. See, the tail is as a decoration, it's a gift. It's very, very nicely presented. Okay, so now here is it now. Oh, so stupid. Now we need to find the other one. Samir, I lost everything. Not used. The second email is probably the one. Here. That was the second probably, yeah? It was a second on the... Oh yeah, this one. This one will be a bit shorter, so we'll be in time. I'll give you all this package, you can take this one, this whole one. You have it on the computer, it's with the WeTransfer. I don't know what's the best. Yeah? Oh yeah, okay. You they get it on through the mail.
Here it is missing the left hand.
But this is the correct length of the suture also. How much is it?
Okay. That's a bit better. Eh?
Yes, sir.
That's okay. Okay, so that was less tiring this session, eh? Yeah? Okay. And you look now on your assessment that you see that actually with such a tool you can assess the process and you see the difference between someone who has a major problem and here the tissue is also at the end approximated nicely and the process was within a short time, which is also one of the criteria, and the movements of both hands, also the left hand was participating in the process. So actually we come to the conclusion that this form works as a tool of assessing the process. For the procedures as laparoscopy or appendicectomy, we use the same for both if you do it on the organ within the training box or if we do it on the virtual reality, because it is complementary with what the system has registered. So this kind of competency assessment protocol allows you basically to assess how competent the person already is. As I mentioned, the downside of it is that it is procedure specific. It means that if you have several procedures in the training program, then you need to have different protocols. In comparison with OSATs, which is non-procedure specific, it allows you to assess any procedure and also to assess behavior of a trainee in VOR. So these forms are more for skills lab use and assessing the videos, while the OSATs are more suitable for assessment at the workplace, because certain aspects of knowledge and of set in VOR and also communication in VOR, the leadership is more represented in OSATs than in CATs. But for skills lab, of course, it would not be again something that you need. So because there is no communication with the team and there is no patient is or virtual image or a box. So the choice is actually a bit complex. For skills like you need some other protocol than for the clinical use. And again, more generic protocols are more universal, and in practice, if you have too many protocols in storage and everywhere, then they are not used. So sometimes it's better to use one for different procedures instead of procedure specific. So I understood that 4 o'clock was the time of closure. And so at the end of the day, usually we ask the participants what was really annoying, what you did actually miss in the day. In our skills lab we don't have daylight, so people are missing the deadline at the daylight, and they are missing the airco is a bit tough, so it's pretty cold. So ladies are always complaining about cold. So these complaints we'll not have today. Maybe you have some other complaints that it was boring or that we are missing something special. But it's difficult to know what you're missing if you don't know what's there in the box. But some things that you expected more to hear today. Maybe if a group would be smaller, you would have more opportunity for doing things. But unfortunately, with such a large group, it's technically impossible to give opportunity to do more on simulators. Within the group of 12 people, we do the same. We have 3 lab mentors then, or 4 even. So, but in the group of 12, everyone can do a procedure, and the peer can be the mentor, and we can change, and we can do some work in on the boxes with rather intense suturing. So you can notice that people that never did tie a knot, so even did not know how it is done, so they were actually unconscious, incompetent, come almost to the level of conscious competency. And the one that has more problems with the psychomotoric skills will come to the unconscious competency that says, okay, now conscious competence, incompetency, that says, I know now what I should learn, but I have still difficulties to execute it correctly. So this is something that in such a setting where the group is smaller, you can really experience yourself. But with almost 30 people, you cannot manage. So I would say, from my feeling, this kind of training should happen with a bit smaller groups, with more exposure, because then you are more proactively involved in what is told, and there is not so much talking and more talking during doing, which is much more informative. Okay, and you have for tomorrow some announcement for people?
Tomorrow morning the first session will be at Charaka Auditorium at 9 o'clock. 9 to 10 we will be explaining about all the mannequins that are there in simulation lab, what are the uses of these mannequins that are there in simulation lab, and what techniques we can perform on these mannequins. It will be dealt by a technical person specialist from London, myself, and Dr. Mishra will be also demonstrating one example of an IV arm on how we can use an IV arm in training. So the same way we can use the OSCE scale for the other techniques also accordingly. So that will be the 9 to 10 session. It will be followed by a session from Jackie Movisir here again in Smart Lab. And we'll also have an expert from Gynec department, Dr. Sonakshi. She will be coming through an online session from London, Mumbai. She will be dealing more about Gynec simulation. We are having Dr. Chakra Rao sir coming from Kakinada along with our medical superintendent sir who will be coming here and dealing with CPR mannequins based BCLS, CCLS, and how we can incorporate it for our undergraduates for different specialities. We'll also be continuing the same sessions by Professor Jackie Movi, and any further questions about your concerned departments will be dealt in the afternoon session. That's it. Thank you.
Okay.
Please take the tea and snacks which are there outside before you. Thank you. And your phones can be there. Please write your name. Please write your name.
सूचन करना है, सेकेंड टास्क नोटिंग करना है, दोनों एक ही आदमी करना है। एक आदमी अच्छा किया, एक आदमी more trying to push it at exactly 9 o'clock exact टीचर का
session నాదే నాడు ఫస్ట్
మజాగా నోట్ చిన్నగా చేస్తారా
Madam, come. ఇక్కడ పంతే ఏం అవసరం లేదు వీడియో రికార్డింగ్
फास्ट फास्ट का